right, thank you and welcome. We're excited to kick off the County Action Network with participants on the line today. This is Optimizing Antimicrobial Stewardship, Putting Strategies into Action. And your usual host, Tina Schween, is out of state today. So my name is Selena Bolleton. I'm the Director for Care Transitions and Patient Safety at Qualis Health. So let me take a minute to do a little housekeeping. We're going to have the phones on mute until the end of our presentation, and then we'll open up for discussion. So feel free to type questions into the chat function during the call, and we'll either address them along the way or we will revisit the questions at the end when we open up for Q&A. Moving on, just to keep everyone oriented here, is there are three HAI Action Networks being sponsored by Qualis Health at this point, the Catheter-Associated UTI Network, the C. difficile Network, and this is the series of calls today that we're doing for that, and then there's the SSI Learning and Action Series. So most of you know that this is the second in a four-part series for the Antimicrobial Stewardship webinar series. Today, we're taking a site visit to Yakima Valley Memorial Hospital, and then in March, Harborview, and lastly, Providence St. Mary Medical Center in April. So our agenda for today is we're going to go through homework from the January 25th call briefly. We're going to talk also briefly about the model for improvement. Then Yakima Valley Memorial is going to share their work with us. We'll have panel reaction, and then lastly we'll have some discussion and opportunities for questions and answers. So let's move right into our homework report. So we don't actually have a hand-up function today, but I would ask those participating if you could chat in, firstly, if you did the homework from the January 25th call, and let me just review. The homework was to discuss the team section on your current state summary. And so we would ask, did you discover, is anyone missing from your team that's essential to have on the team? Are the roles clear in the team? How often do you meet, and is that clear and frequently enough to make progress? And then what are your team goals? So we're going to ask those of you who did your homework to go ahead and chat in those results of the homework, and other folks will be able to, on the call, will be able to see some of the results in the chat function. So as participants are doing that, whether you're in team structure or other elements of antimicrobial stewardship, when you're thinking about making changes or refining processes, it can be helpful to ask, what are we trying to accomplish? How will we know if a change is an improvement? And what changes do we think will result in improvement? And then to go ahead and test those assumptions systematically. So that means keeping it small, and keeping it small is, it could be the steps in the process, it could be your sample size, it could be the duration of the test, and I think it's important to add that testing one thing at a time will help you know whether that change made a difference, rather than confounding it by making too many changes at once. So some other key elements, tips, don't get mired in planning. Pick something that you can do pretty quickly, as we say, by next Tuesday, and then learning from that test, adapting, adopting, abandoning, based on the experience that went with testing that change. So this, of course, is known as the model for improvement. Again, what are we trying to accomplish? How will we know that a change is an improvement? and what changes can we make that will result in improvement. And again, that all involves the Plan, Do, Study, Act, or the PDSA cycle. So we're going to talk about just a brief example kind of to go through the model for improvement. So what are we trying to accomplish? Well, let's pretend that this particular team wants to monitor prescribing and appropriateness prior to giving that first dose of a restricted antibiotic. How will we know that a change is an improvement? This team is saying that an increase in appropriate usage, appropriately prescribed dose, will know that we've seen an improvement. So what changes can you make that will result in an improvement? So the changes would be that are being postulated would be that real-time appropriateness audit by a pharmacist when a restricted antibiotic is ordered. So marrying that order with having a real-time audit about the appropriateness. So here's a PDSA cycle. This would be the first cycle. The plan would be, in this case, this is an example of keeping it small, picking one pharmacist on one shift and one restricted antibiotic to monitor, and having a method to determine the appropriateness is important with criteria, and then that would include calling the prescriber to clarify the order if it was not met, and in doing that one time during that one shift. So the do part of the cycle, take notes on what happened, what you observed. Study part, what was learned by doing that one small test of change? What went well, what did not go well? And then as the final part of the PDSA cycle is deciding upon those results how to adopt or what to change, what to adapt, or if that didn't work, looking at what would you try next as one small test in the next PDSA cycle. So I want to introduce today's guests. We have Greg Matsura from Yakima Valley Memorial Hospital, who's going to share the work that they're doing at Yakima Valley. Greg is a clinical pharmacist and is the coordinator of the antibiotic review team at Yakima Valley Memorial Hospital. He's worked as a lead pharmacist for 3 years before transitioning to an on-site clinical faculty position for Washington State University. Greg currently serves on the board of directors for the Washington State Pharmacy Association and is on the Clinical Informatics Section Advisory Group for the American Society of Health System Pharmacists. So we're so thrilled to have Greg share with us today. After Greg gives his presentation, we also have expert panelists who are going to share their thoughts after the presentation and will help us through the question and answer period as well. So we have John Pauk, who's the Medical Director of Infection Control and Antimicrobial Stewardship at Swedish Medical Center, and John Zarek, who's the Director of System-Wide Clinical Pharmacy at Swedish Medical Center. And both of our expert panelists are members of the Antimicrobial Stewardship Committee of Seattle. So I think at this point, we're ready to switch the presentation over to Greg.
All right, excellent. I appreciate people taking their time to dial into this webinar. I especially thankful that Qualis took time to actually ask if I would present my facility at Yakima, Washington Memorial Hospital. So I am the antibiotic review team coordinator for the site. And so I'll be giving this presentation on what we've tried and how we developed our stewardship programs over here at Memorial Hospital. So Memorial Hospital, just to give sort of a scope where I'm coming from this presentation, we are a 225-bed acute care community hospital. Our providers are a combination of both community providers, plus we do have our own inpatient hospitalist service. One interesting fact that we've had that's new in our area is now that we have 3 different independent ID specialists. these ID specialists actually have different offices. They are non-affiliated with each other. So it has an extra dynamic in our community that we haven't had in the past couple of years. More specifically, with our AMS team, we have about a half-time FTE allotted. Now, my time is actually split between stewardship activities and clinical informatics activities for the pharmacy department in general. So it's actually a part of the FTE that's allotted to stewardship, but there's a lot of synergy and overlap with some of my functions. Generally speaking, I meet with the ID physician about 1 hour a week, and we'll either go through case presentations or we will actually go over larger global sort of problems, let's say, in regards to stewardship. Of course, we include infection control and microbiology. Pretty much we exchange calls daily, several times a day. And then a key point are the clinical floor pharmacists that I work with. We do have 5 clinical separate teams on our floor at our facility. So, one of the themes of this presentation is, at first, if you don't succeed, try again. Or as Henry Ford said, failure is only the opportunity to begin again, this time more wisely. So, at least with stewardship, we've been at this for quite some time. Our original start was actually over a decade ago. So in 1999, we actually initiated what we call the antibiotic review team. So this is a antibiotic stewardship program. What this consisted of was a combination of interested staff pharmacists and an ID physician. What we found, though, is that there was a wide variation in interest and skill sets between the group. And so the dynamic wasn't optimal. So we actually went through sort of a reboot period in 2001, so this was a pharmacy residency project. So we had staff pharmacists, an ID physician, and plus a pharmacy resident. We found the same issues apparent where there was a wide variation of interests and skill sets. So about from 2002 to about 2006, we did stewardship as needed. Pretty much when we had specific cases to bring to the ID physician, we would talk about it, but we really didn't have any sort of sustained or structured effort at this point in time. A bigger change from 2007 up to present is where we're really a much more focused team at this point in time. And we've had a lot of changes with our staffing model and actually on a lot of the systems that we use. So at our facility, the structure that we use is the stewardship coordinator serves as sort of a central hub. So infectious diseases, the clinical pharmacist, microbiology, and infection control. And so the stewardship coordinator serves as sort of the hub of information exchange. And we found this to be a lot more efficient when interacting with several different groups. What we were doing before was sort of a round-robin system. And this wasn't nearly as time efficient as we wanted to because several different players were involved, but no one really had the opportunity to connect the dots. Or if the dots were connected, it took relatively a long time. The other part that we found out along the way is that it's really hard to do things manually. Now, at Memorial Hospital, we were large enough where it was hard to do things by hand, but not so large that we could justify buying a third-party vendor software. And so what we did over time is to use the tools we had at hand and manipulate them to help with antibiotic stewardship. And so we had the resources that a lot of facilities had at hand, an electronic pharmacy order entry software. Later on, we had barcode administration, and then finally physician order entry. But none of these systems were specifically made to do stewardship. It was just a lot of information. So over time, what we used these systems, at least the information we found, to actually be used as tools for stewardship. So 2003, we started off with an electronic database mining tool, and we could find our patients. As we've gone on throughout time, we actually made this a lot more sophisticated, adding culture results. We could find out if there was actually an ID consult or the hospitalist on board. And then more recently, we just added a bug-drug match system that's actually integrated into our EMR. So our EMR never had a native system to do that, but we found through using a common language called Arden syntax that we could program it to actually do it. And we can actually alter the EMR system to generate alerts in real time. One more recent part is we found all the barcode administration data that was really just sitting there. And then we realized that we could use this to actually monitor the number of doses administered and actually extrapolate duration of therapy and in the future length of therapy. So this is just a screenshot of the report that we use. Now, one thing is this is not actually anything that was created specifically for stewardship from a vendor support area. So this is actually just a PDF generated through an Access database. So what we did was link up a lot of the bits of information that were all over the hospital and made a report that actually is generated on demand for antibiotic stewardship. And so this made us a lot more efficient instead of using more of a manual system, which we were regulated to, at least initially. So the system that we use is from that PDF report. We actually can find the patients that are on targeted antibiotic therapy. The other part is that we use follow-up notes that are entered in by the floor pharmacist and the evening and night pharmacist, which just gives us more or less a heads up of patients we would probably need to review. So it's not so urgent they have to change the physician, but at least there's something still in question where somebody would request for us to review a patient. Sometimes it turns out to be a non-issue. Sometimes it turns out to be a very big issue. But what happens is this creates more of a focused sort of intervention on the broad group of patients in general. From this information, then, of course, pretty standard. We review the electronic medical record. Since we are a smaller facility, I can go up to the floors, talk to the nurses, floor pharmacists, interact with microlab. From that point, though, then we collect all of our information, then we discuss it with the ID physician. And so I work with Dr. Neil Bard, and what we do is we have a system where we have regularly scheduled meetings, but also we kind of do as-needed conversations, either face-to-face or via phone, especially if it's an urgent issue. And with that information, what we do is we do similar to the Swedish model, but more of a shoestring version, is where we have direct patient case discussion with the physician, and we're doing prospective review with feedback with these physicians. So for our targeted review, the ones that we actually focus on are the ones with initial diagnosis therapy mismatch. And so from our report, what we can see is if there is a diagnosis that is inconsistent with therapy, it really focuses on our time. So if somebody has diverticulitis, they're only on Flagyl, we take the time to figure out if this was a meaningful use of the antibiotic, or is there some part of this, the actual therapy that for some reason or another was omitted. Of course, more bread and butter, we match up the isolate if it's resistant or not covered with the current antibiotics. And then, of course, we do IV to PO switch antibiotics that are appropriate for oral therapy. This tends to be in more of the realm of the clinical floor pharmacist, but we will do this from time to time, mothballing it in with some of our other recommendations. More of a long-term review is what we have with broad-spectrum antibiotics. Usually by about day 3, we have enough information with cultures, diagnosis, that we can actually start trying to do some de-escalation at that point. Another sort of time trigger that we use is when the antibiotic duration goes over a week, then we start making sure that therapy has some sort of endpoint in mind, depending on the diagnosis. By that time, most of the patients will have a confirmed diagnosis, or at least the working diagnosis is pretty well set, and so a lot of decisions can be made at that time. Finally, we do targeted review based on antimicrobials. Generally, there are not very many surprises on this list, of course, very broad-spectrum antibiotics. Other ones like vancomycin or antifungals, of course, are of interest. At Memorial, we do have a restricted formulary, and through our P&T committee, there are certain antibiotics that are required to have some sort of stewardship review once they're ordered. The physician can order them, but the trigger of the review is required, and so it has to either have an ID consult pending, or at least a discussion has to occur for the antibiotic to be continued to be used. So the information that we have for our activities for our stewardship team, this is just an extraction of interventions that we had over a 2-year period. Now I want to point out, what we wanted to do was similar with Swedish, where we wanted to avoid sort of the double dip effect, where the stewardship team was documenting things, and plus the clinical floor pharmacists were documenting things. The reason is because we actually report to administration our interventions or activity per team. So if 2 people were reporting on it, then we would have, unfortunately, the interventions wouldn't be that accurate. So we tried really hard to keep the stewardship team's interventions separate from the rest of the clinical floor pharmacists. So over this 2-year period, we noted that we de-escalate or try to streamline antibiotic therapy. About a quarter of our interventions relate to this. Because we are a smaller facility, we do more of the dosing changes, particularly in our, unfortunately, morbidly obese patients with changing renal functions. Continuing on, the next frequent intervention is the antibiotic mismatch, where, of course, there's either a resistance problem or, unfortunately, the spectrum actually misses the pathogen in question in the first place. Finally, we have IV to PO switch, but again, since this overlaps with the clinical floor pharmacist, this only represents about 10% of our interventions, so only a minority of activity. So I wanted to throw in a case example, because stewardship is more than just monitoring the antibiotics and making sure that things kind of fall into the right place. There's a lot of activity that we would actually consider as more of a near miss. And so this is an example that happened, let's say, within the last year or so. A case that I interacted with, this is a 58-year-old male with recent chemotherapy for leukemia. They were admitted with neutropenic fever, and they were started empirically on cefepime. So this happened over the weekend, and the fever's improved, and the ANC recovered by day 3. So the pharmacy receives orders to DC the antibiotics on day 3, and the physician chart notes is to stop antibiotics and observe. Because they're on cefepime, when we had review for this patient, they ended up on the list anyway. And so when we reviewed the patient, even though there was a stop date added to the cefepime, we noticed that there were actually blood cultures that were available, and there was actually 4 out of 4 blood cultures positive for MSSA. So our intervention was to notify the physician via their office and inform them about the bacteremia. And so the physician that was attending obtained an ID consult, and nafcillin was started pretty much as soon as the ID consult got there. So this was an example of maybe it doesn't fit into targeted review specifically for reduction, but it shows where a stewardship program with continuing monitoring of antibiotics can actually help out with the near misses. Another example is kind of where it comes from. If you don't notice there's a problem, how can you react to it? And so this is a minor example with azithromycin. What we notice is that over the years that we've had, there was an increasing trend of azithromycin use. But we really didn't notice it until it kept on coming up. And I'll have to give some comment that it was really nice that the Providence over at Sacred Heart and Spokane allowed for me to do a site visit, because they had a specific activity that was focusing on azithromycin. And then when I went through the numbers, I realized that we were using more and more of this antibiotic pretty much with the same patient load. Pretty much the case in point was we had patients with a penicillin allergy, and over time what we noticed is that prescribers tended to rely on more azithromycin just so the allergy was there, and it was less of figuring out if it was a significant allergy as much as avoiding the question altogether. So about the second quarter of 2001, we started doing more investigation to each of these patients that were started on azithromycin empirically. And what we found is that there was some historic record within our hospital system that they could tolerate a different beta-lactam in the first place, and they tolerated it for sometimes quite some time. And so we started interacting with these prescribing physicians, and we were able to have downward pressure to this increasing utilization. Another example where we had information that was actually a little bit surprising, and it kind of reiterates a point of how you monitor antibiotic use. So one of our focus antibiotics was pictase or Zosyn. And going through our administration data from the bedside administration system that we have at Memorial Hospital, what we found over from 2009, 2010, 2011, our defined daily doses for 1,000 patient days really didn't move over this 3-year period. But the interesting effect is that since we kept on having pressure on it, the duration of therapy actually was reduced. And so there's a lot of theories behind, okay, why did the duration of therapy show a change versus the actual grams of use? One thing is heavier patients, were we not using maximum doses? What could we in certain specific patients? But the interesting part of this data was that the grams of use may have not been in line for some antibiotics for the overall duration of therapy. And because, especially with C. diff infection, what we're trying to do is reduce the overall exposure of an antibiotic. So when we use an antibiotic, we want to use it optimally for as short a period as possibly effective. And so this was an interesting, a little bit eye-opening data set that we actually were extrapolating that showed that the defined daily doses may not be in line with the duration of therapy. So another point that we had building our stewardship program was that we really wanted to have a drug bug match system, but we pretty much had to do this from scratch. One problem that we noticed, or issue, is that even with the electronic medical record, is that there was no automatic system that would alert a physician or a prescriber if something became available and how relevant was it to their patient. It simply updated in the system and waited for somebody to actively search through the information again. And so what we did is generate a system that actually generates alerts in real time that's integrated in the EMR. And so the system is actually triggered by the updates in the micro report. So the advantage is it updates in real time. As soon as the culture results is available and microbiology has updated the information, the system reacts to it. So it doesn't take somebody to sit and monitor when the report actually occurs. The one thing we noticed, though, is that because it's triggered by the micro report, the unfortunate sequence of coming off effective therapy, the system doesn't have a strong ability of determining that. It actually just has to wait for the next update in the micro report. The other part, which wasn't surprising, and this is why we actually keep the alert at this point in time only to the stewardship team, is that it doesn't scale to clinical relevance. So it simply reports out if there's some sort of resistance to all the therapy that the patient's on. So if they're on 3 different antibiotics and it's resistant to all 3, then it generates an alert. But it doesn't really tell us if it's a significant result or not. It's simply just making a report. So these alerts still have to go through clinical review. And so most of the alerts that are generated, we still have to pick through and determine, was this something that, or is this something that needs to go out with the page, or is this more of an observation? The other part that we want to focus on is the preliminary pathogen descriptions. So right now, what it's set up as is it will react to anaerobic results by their descriptions, but we would like to add things like fungus, particularly in the cases of candemias or cases where we suspect Pseudomonas, such as non-lactose fermenters. And so we can actually make this a lot more sophisticated because we are actually creating the system within our EMR, but it does take some time. So in regards to antibiotic stewardship and C. diff infection, we've actually been working on this for quite some time because broadly we know that we want to limit antibiotic use, particularly the broad-spectrum antibiotics, and continue to have this downward pressure. So we've been working with infection control on all the cases of nosocomial C. diff infection. So once we have a listing of these patients, the stewardship team actually reviews the list and looks for trends or associations to see if we have a particular problem with a specific antibiotic, or is there some sort of trend that's going on that we need to react to. Now, all I can say casually is that we do have a decreasing trend toward nosocomial antibiotic-associated C. diff infection from 2009. But quite frankly, our actual rate is so low that we can't really determine any meaningful cause and effect in regards to the antibiotics. We just note that sometimes they were there for certain cases, and then the other times they have other associations with other complications. One facet that we're adding to our C. diff infection report is the association of proton pump inhibitor use and C. diff infection. At this point in time, we're not sure exactly what this information will be helpful toward, if it will show us if there's a strong association or not. But again, our numbers are generally very low for our facility, and so we're mainly just monitoring it to see what sort of information can come from it. Now, our future steps is that we are still improving our drug bug match alert system. Since this is an integrated system from the EMR, there's always room to optimize it. Since we are actually in control of the system without a third-party vendor, we can actually manipulate it to becoming more specific to our facility's needs. And so we're continuing to find where the alerts could be further optimized to prevent more of the chaff prevent the chaff along the way, so a lot of the alerts are more meaningful. The other part is now that we have our medication antibiotic use directly from the barcode administration system, is that we're trying to improve feedback to the prescribing house staff. An interesting dynamic we have at our hospital is that now there's a large increase in the patient proportion seen by the hospital's house staff. And so more specifically, we are going to bring our information to their March meeting just for informational purposes, not so much as coming to them saying that we have a problem, but showing them that as a facility we are very interested in antibiotic stewardship, and these are the tools that we have for monitoring, interacting, and implementing some sort of change along the way. One other interesting point is that we had computerized prescriber order entry started at this facility, and that provides electronic data on prescribing even at the provider level. In conjunction with the barcode medication record, this really allows us to stratify antibiotic use to particular services or even by their severity of their disease, because once we have this information, we can actually line it up with IDC-9 codes and really stratify our information rather than just say broadly we have antibiotic use house-wide. We can actually focus in on more of our specific floors and see if there's any trends. Another part is that we feel that continuing to remind people why we're here, what we're doing is really, really important. So we have been doing a monthly clinical vignette with the family practice inpatient service about antibiotic use and antibiotic stewardship. So this provides another forum for the in-house prescribers that aren't necessarily hospitalists, house staff, but the next major group of prescribers for at least our facility. So finally, with our AMS experience at YVMH, things that we've learned along the way, and this is fairly intuitive, but I still feel the need to reiterate because it's really made a difference. It's a team approach. One of the parts is that the floor pharmacists are really an extension of the service. At Memorial, we do not have a centralized method of contacting physicians. And the hard part, since there's only one of me, it's very hard for me to page or talk to a multiple group of physicians within sometimes the same morning. So what the floor pharmacists help out with is particularly they find issues that may have not been as high on the radar, and they can help focus our interest, but also they serve as connectivity to the prescribers. A lot of the prescribers know the floor pharmacist by name or by sight, and so they provide this communication forum that's already been in place, so they really extend our ability to affect prescribing. The other part is the coordination with other departments, particularly infection control and microbiology. There's a lot of different bits of information that are out there. but unless you connect the dots with the other departments, trends or observations may go unnoticed. So it was particularly helpful to include them with the stewardship process. The other part that we found, which isn't too surprising but still an important point, is information is key. What we found is that prospective data mining has proven to be invaluable. Because we are not a large facility, but large enough where we need some sort of efficient system to find the patients, we found that prospective data mining is actually very, very helpful to help with our targeted review. The other part is, of course, fairly intuitive also, is knowing more faster. But the key is exactly what resources could we use to actually generate more information in a shorter period of time. So an example was the bug drug match alert system. So instead of checking the electronic medical record over and over, seeing if that culture was updated, we were able to use the EMR to actually generate alerts for us. And so when it became populated, then we realized maybe we have a problem, and a particular patient may need an intervention. That being said, it's always been our view that we don't need to recreate the wheel. So we're still evaluating potential third-party vendor systems for antibiotic stewardship. In part, we want to see what's out there. One thing is sort of as this forum is, it's hard to come up with an idea spontaneously sometimes. And sometimes you need that extra push to see what other people are doing and realize that it can be done at our facility. Maybe in a different way, but the flavor is still the same idea. And so with interacting with these third-party vendors, we can actually see what's on the horizon and then have at least an open forum of, okay, these are our needs, what can be provided. At this point in time, we haven't had anything that lines up perfectly with us with the resources we have, but we're continuing to look for that. So in conclusions, I would like to have some acknowledgments, especially for the ID physician who has worked/put up with me for the past decade. Dr. Neil Barg, also the assistant manager of pharmacy services, Angela Stewart, microbiology with Maria Clark, the infection control nurse with Jayla Langley, and then the other part, which is also very, very important on the same scale of all the other players, is administrative services. So Sandy Dahl was the VP that's associated with our stewardship team. So without sort of the view that this is important, there would never have been even a fraction of an FTE assigned to the stewardship program. So with that, I would like to end my presentation field trip of our facility and open it up for any sort of forum, conversation or questions.
Greg, thank you so much for letting us all get on the bus and make a field trip to Yakima Memorial and hear what's working for you there, and sharing that with so many other providers. So at this point, we're going to go to our panel and ask any comments or reactions about the model for improvement, Yakima Valley Memorial Hospital's approach to antimicrobial stewardship, and particularly around adoption considerations, since we want to spread great ideas and best practice.
This is John Palk here with John Zarek. Greg, thanks for the great presentation. I think your talk was a great presentation of the way that individual hospitals can kind of individualize what their programs can look like based on their resources in terms of the hospital size, what their pharmacy support is, and what their information services are. So I think it's really great to see a picture of how you could adapt what you have and put it to best use in a really innovative way. So I think that's great. I also think the theme that you had of how you engage your key stakeholders, going out to the hospital, to family practice, and trying to engage people who are going to be working on your interventions was also excellent. And that, I think, is probably a theme that overall we've looked at here at Swedish, is how do we get great acceptance and get feedback from the people who are the end users of our service, and how can we engage them to be good customers and actually seeking out our help. So that was great, your emphasis on that. So I I'd like to hear what John Zarek's thoughts are from the pharmacy perspective, and then I do have some questions after that about how you evaluate the impact of the program.
Yeah, Greg, this is John Zarek, and audience out there. I think that this was an excellent example of how antimicrobial stewardship can be incorporated into a smaller one facility setting. It's clear that many organizations do not have a great deal of resources, and the work that Greg has done, and it sure seems to be, to me, a labor of love for going a decade with this approach, to show how that emphasis can lead to some success. I laud Greg for his targeted approach. He has limited resources, but he went after things such as the patients with initial diagnosis therapy where there was a mismatch, a very important area where appropriate antibiotics should be utilized. Also, the isolation of resistant or not covered antibiotics, broad spectrum therapy for more than 3 days. These are very excellent examples of how targeted approach can make a difference in settings where they have limited resources. I was also pleased when I was listening to the talk about some of the successes in terms of the interventions and the types of interventions. Greg's interventions with respect to streamlining and de-escalation kind of match what is occurring at Swedish and antibiotic mismatches also. But dosage changes, it just shows how unique situations in particular hospitals, dosage change was a higher priority, ensuring safety and patient safety, and I think that was very good. I also just want to laud that, again, with the resources available, this is really a creative use of the present systems that you had, and all organizations, if they have limited resources, can start in a small way and begin to make improvements. So thank you for letting me provide this perspective.
Greg, I have a question for you about, you pointed out your targeting of ASP-M and how often inappropriate allergy history was driving use of that drug. And I'm kind of curious your thoughts. We do see that inaccurate or incomplete charting of allergies often does drive the inappropriate use of antibiotics, not just ASP-M, but some of the carbapenems, or not using cephalosporin where it may be the best drug, and using quinolones or vancomycin instead. Based on sort of soft penicillin allergies. I wonder how you went about it as a hospital, trying to get the right allergy history in the chart, and if you have any thoughts about ways hospitals could maybe do a better job of that, because I think that's a big driver of perhaps inappropriate use.
Yeah, so thank you for also the kind words about our antibiotic service, in particular from both of you. Specifically for that question is that we've kind of an unusual situation over in Yakima Valley that we actually have two different hospitals, but we have most of the admissions at our facility. The other part is that they have an electronic medical record that's used on the outpatient, and what a lot of the independent practitioners have done is allowed the hospital actually access to their patient's information, particularly because we have to do home medication reconciliation. But what I found is between our historic records and also the electronic records from these outpatient providers, it was a whole slew of information of what were the real allergies and what was used previously. And so it was an easier battle when we could show a practitioner that they had some sort of cephalosporin use in recent past or several times in the past. The prescribers felt a lot more comfortable, even though they weren't able to elude out what the reaction was maybe with their penicillin. And so our information and their background was a little bit unique in our area because we had so much information sharing, but it was really, really helpful in the same sense because we understand that when you're admitting a patient at 1 a.m. or 3 a.m. in the morning, drug allergies, the specific information may be hard to get to. It takes some time to find the information. But as the practitioners became more comfortable and the information became a little more refined, then we noticed that people were using S3M less and less.
Greg, one other clarification. When you're looking at your targeted antibiotics, you used defined daily doses, and then you had DOT. I heard you say duration of therapy. I was wondering if you meant days of therapy.
Oh, yeah. So days of therapy or duration of therapy. I guess in a certain way, because what we had to use is the barcode administration data. And so actually using Excel logic to determine how long somebody was on based on the interval that was prescribed and how many doses they actually received. So, yeah, days of therapy would probably be a more succinct sort of term.
So, Greg, I have a question about the impact of your interventions, recommendations, when you're working with a system with hospitalists and family practice who are involved with the patients, and also 3 different ID doctors who have different practices. I wonder if you had any sense of what the acceptance rates of your interventions was, whether you feel like it's where you want it to be, and also a little bit about if there have been barriers to acceptance of the program or whether it's been embraced, and any sort of insights about how hospitals can improve on that front.
So unofficially, about our acceptance rates depends from year to year, but it kind of goes between about around 85%, sometimes a little bit down as low as 80%. And so that's kind of our range of acceptance. Unfortunately, I don't really scale it to actual significance or if they actually accept it later on, but by then it was sort of a after-the-fact notion. But that's kind of our acceptance rates. Now, more specifically, with providers, we noticed there was a specific trend because since I tend to do most of the interventions in the stewardship, we did notice that there were focus groups that had particular behaviors. It sometimes did create somewhat of an issue because we noticed the focus groups had a certain mindset set of how they wish to prescribe, and it comes from a different viewpoint sometimes. It helps, of course, immensely to have an ID physician to back the comments of the antibiotic stewardship team, but sometimes it was a little bit harder, especially from my sense, where I was giving unsolicited advice toward a prescriber, and sometimes it had to do with interpretation of the information at hand. And so we always respect the clinician's judgment, but sometimes we would have a disagreement. And it was difficult, especially if particular groups had decided that it was not their focus interest. I could say, honestly, we've had some changes in the community where things have shifted over, and so not by any part of what I've done, but some of the groups have, for lack of a better term, gone away. But it is an issue and an ongoing sort of theme where there's sometimes focus groups where it is a little bit harder to convince them that it's a good idea.
Operator, we just have a couple minutes left. Let's make sure we have a chance for some questions from other participants while Greg and the panel could continue to chat. But let's see if we can get some participants in the queue with questions or comments.
So I'm curious if could you describe what you do on your monthly meetings with the prescribers? How do you get them together? What do you discuss? How do you get them there?
Oh, so at least with the family practice group, it was really easy. They actually invited me to speak to them on, it was on a weekly basis, but that was a little difficult, so we changed it down to a monthly basis. And so it was a great opportunity because what they wanted was some more insight on antibiotic use, but also at the same time I use it as a form of this is proper utilization and stewardship in general. So that group, it was really, really easy because they came to us. The hospitalist service, we have a very good working relationship with their director, and so it was pretty much just ending up on their docket to talk with them. And I've worked with a lot of the hospitalists for years, and so we have a very strong working relationship. And so what I felt was important was develop those relationships and then start talking to them about stewardship rather than coming to them talking about stewardship and then having them hopefully figure out that this was a good idea and I'm okay to talk to. So I kind of did it for more of a small scale, get familiar approach, and then start being more interactive and have more feedback.
Hi, this is actually Qualis Health, one of the pharmacists at Central Washington. Greg, I just wanted to know a little bit more about the language that comes up in your electronic alert when the microbiology there's an update. And does it appear on a summary page on the patient? Could you just share a little bit more about that?
Oh, okay. Excellent. So the way that the system is right now it's only available for my interface. So when I log on to electronic medical record, I'm the only one who gets alerts. The reason is because we didn't want prescribers to, as we figured out the system, to be for lack of a better term, turned off because of maybe over-alerting and insignificant results. That being said, we're setting it up so it can potentially go to prescribers at a later date. So the alert, what it says is that you have a mismatch with this antibiotic for this culture. It actually links to the culture. If they click on the alert, the culture will pop up to which result actually had the resistance pattern. And then it says also on top of the alert that this alert does not signify how significant this alert is for this patient. It's simply alerting you to information. It does not actually tell them if it's a critical problem or not. And it makes a little caveat at the bottom of the alert that this does not take the place of clinical judgment. So that's at the phase right now.
Thank you.
This is Selena. I wish we had time for more questions and answers. I'm sure that Greg would be happy to respond to any particular questions after the webinar. I want to thank Greg Metsura and John Pauk and John Zarek for sharing with us today. And I just want to quickly move on to some suggested homework. This is from the core strategies on your current state summary. So if you would take a look at that and you and your team ask how is the current strategy going, what could be better, and identify at least one refinement to test in a Plan, Do, Study, Act prior to the next webinar. I want to remind our participants that the next webinar is on March 28th, and we're going to get on the bus and go to Harborview and hear about their antimicrobial stewardship program. So again, March 28th, and then we'll end up the series at Providence St. Mary Medical Center in April. So I want to thank everyone for participating today. Some of our contact information is on the last slide. And I just want to say that we did not do a great job of describing how to use the chat function. So we got the results perfectly as we planned them. And so we'll get better in a PDSA cycle next time on our next webinar. So thank you, everybody, for participating today.